and I look forward to virtually seeing some familiar faces out there. I know several of my colleagues from New York are logged on already. I can see your names. So it's exciting to be here today to present on behalf of the IAS-USA. I'm going to start with just some background information about the course today. This is the CME information for those of you who are interested in getting CME credits, and also information about nursing and pharmacy credits. And it sounds like that information will also be emailed out to course attendees along with the evaluation afterwards so that you can get a better look at all of this. The following supporters provided grant support for this webinar today. And this is some information for those of you who are still learning how to navigate these webinars, as all of us are, about navigating the webinar here. There are going to be some poll questions today and some information, a couple of audience response questions throughout today's talk. You're also able to, if you have questions that come up during the talk, you're able to type into the chat box. I have discovered that I find too many things open on my screen at once and probably won't answer new questions in real time, but I have read some of the pre-registration questions and will try to address some of those, particularly the more commonly asked questions as I go along. So the first poll question is just to give us a little bit about who you guys are. For those of you who don't know me, I'm Christina Wyatt. I am from, technically originally from North Carolina, did most of my years of practice and HIV care as a nephrologist in New York City at Mount Sinai, and is now back at Duke in North Carolina for the last 2 years. I thought I had escaped the coronavirus epidemic, but we actually now have one of the highest rising incidences in the country. So I'm interested to see where the rest of you folks are from. Looks like it's going to be a race between the Northeast and the Southeast United States. All right, so it looks like, again, pretty much a tie between the Southeast and the Northeast United States, a little bit from the West Coast, and then a smattering of folks from elsewhere. So again, I think it sounds like we're probably in similar situations in terms of many of you probably at home with children running amok, some still finishing up the school year, some in summer camp, and then those of you who are lucky enough to have adult children are peaceful and productive at home, unlike the rest of us. So I think with that, I'm going to go ahead and get started. As I mentioned, I spent most of my years of clinical practice after fellowship in New York. And while I was there, I was the nephrologist, on-site nephrologist for our HIV clinic. So this is an area, it's also my research area, but this is an area where I really have a huge interest, both clinically and research-wise, in the patient population and in the unique, really unique aspects of kidney disease care in this population. Some learning objectives here. I think at a bare minimum, I hope that leaving this presentation, you can think a little bit about people living with HIV who are at risk for acute kidney injury and chronic kidney disease, be able to distinguish kidney injury from artifactual declines in estimated kidney function that occur with some of the antiretroviral agents, and describe some unique issues in the co-management of kidney disease and kidney transplant in patients who have HIV. So this is a longer than intended pretest question, which is what you get when you forget to submit your real one. So I'm going to read it out loud for those of you who can't read this small text. Essentially, the short story is this is a pretty common patient that I would see in the clinical practice. A 45-year-old African-American gentleman with stable HIV and end-stage renal disease. And he had been biopsied in the past. He had biopsy-proven focal segmental FSGS, not HIVAN, at least not classic HIVAN. He has a brother who is also on hemodialysis, an uncle with kidney transplant, and he recently started dialysis himself through an AV fistula. His medication regimen you can see here is elbapentagravir, Cobi, FTC, TAF. He's on metoprolol, amlodipine, and a phosphate binder. Essentially, he's been referred to a transplant clinic, but he really wants to talk to you. You're his, he knows you, and he wants to think about what his options might be. Both he and his nephrologist have been concerned about having a relative donate because there's such a strong family history of ESRD, and I would also be concerned about this. Certainly, with taking a transplant from anybody who is on the, the side of the family where the uncle has a transplant would probably be, I just wouldn't probably consider it. The nephrologist and his transplant team have also encouraged him to consider accepting a hepatitis C positive kidney, which is something that I'm not going to talk about more today, but is a really good option these days, has actually really opened up the transplant waiting list for patients who are willing to accept hep C positive kidneys and receive treatment for hepatitis C afterwards. So this is now possible because of the direct-acting antivirals. They've also encouraged him to consider accepting an organ from an HIV-positive deceased donor under the HOPE study protocol. So this is one of the things I'll talk about today, and curious to know what people think which of the following statements is true. So first, enrolling in the study may reduce his time on the waiting list, but he's likely to receive a lower quality organ. The transplant team may recommend changing his regimen in preparation for transplant to minimize drug-drug interactions between elvitegravir and the immunosuppressive medications. And finally, the transplant team may recommend changing his regimen to minimize drug-drug interactions between cobicistat and the immunosuppressive regimen. I'll give you folks a minute to answer. Looks like there's a pretty good consensus here, so we may not need to do this again at the end, which is good. It's helpful for me to get a feeling of what people's understanding is at baseline. Okay, so 80% of you selected the correct answer, which is that there would be concern about potential drug-drug interactions between cobicistat and the immunosuppressive medications. And I'll talk a little bit more about these others later on, but essentially transplant from an HIV-positive donor is a potential consideration in these patients, at least in settings where that's available. Great. So I'm going to start with one more clinical case, and this is a very different scenario. So this is a gentleman who was referred for rising creatinine. He's 46 years old. He's HIV positive. Really no other past medical history, no complaints. Looks well, feels well, and is just there because of this lab abnormality. So he's actually a relatively small man when he walks into the office, and his weight's only 57 kilograms. So this actually is relevant because, essentially I had kind of guesstimated his GFR before he walked in the room, assuming he was a 70-kilogram man, which he's not. So now that I see him, I just sort of rejigger all this creatinine clearance. Obviously, weight doesn't have any impact on the other eGFR estimates, so those don't change in this setting. But you can see that this is a gentleman whose creatinine had gone from 0.9 to 1.3 to 1.5 milligrams per deciliter over the course of a couple of months. And you can see how this translates into pretty substantial changes in his eGFR or in his creatinine clearance, despite, again, some discrepancies between those two measures, which are also quite relevant. And I think, the first question here is which one of these do you use? I think this is a really common question, and this was asked by several people. The FDA dosing guidelines are based on creatinine clearance. So at this point, for drug dosing, I would still recommend using creatinine clearance, Cockcroft-Gault calculated creatinine clearance for that purpose. If you're trying to identify patients with chronic kidney disease, the CKD-EPI equation, which is now being reported by most clinical labs, although some still report MDRD, CKD-EPI is actually more accurate for kidney disease staging and diagnosis. Obviously, near dosing thresholds, it's important to use clinical judgment. So if you feel like one of them doesn't make sense or there's a big discrepancy between these two measures, it's important to think about what makes sense. So, for example, if it's dosing for a drug like lamivudine that's got a wide therapeutic window, I'd probably err on the side of the higher dose rather than the lower if you're close to a dose adjustment. If it's a drug with a very narrow window where you're worried about toxicity, then you might err on the side of using a lower estimate. So again, just using the art of medicine here. Also important to consider muscle mass and dietary protein intake. So creatinine comes from muscle, and it comes not just from our muscles, but also from animal muscles. So if people are eating an incredibly high protein diet, in particular animal protein, that can impact serum creatinine. Technically, creatinine should be checked fasting, just like lipids, but it almost never is unless you've asked someone to come fasting for their lipid panel. So that's an important consideration as well. Obviously, great big bulky weightlifters should have a higher creatinine for the same level of kidney function. And then sort of related to the muscle mass question is always asking about supplements. I'm thinking there in particular about creatine, which essentially turns into creatinine in the blood and just makes it hard to interpret the test. And also asking about medications that can affect it. And although you guys have the not quite the monopoly, you have several medications that can affect serum creatinine. The oncologists also have their fair share. So knowing what medicines patients taking is also important. So again, this turns out to be a gentleman who had been taking creatine. This was an interesting discovery because he doesn't look like somebody who's taking creatine. But he had, I think he was planning to go on a cruise with his partner. His partner said, "Dude, you're way too skinny. You got to do something about this." So he was trying to bulk up. He also had recently switched his regimen from atripla to elbitergovir CoB-FTC TAF. And so this was essentially all he was taking, no other medications. So a little bit of thought here about what this could be. So what do we know about cobicistat? We've already talked about creatine. Creatine certainly could have an impact on his labs, and it turned out that the creatine had been started around the time of that first bump in his creatinine. So I think that likely the creatine did have some impact on the serum creatinine that we're seeing now. And the question is whether we can blame the rest of it on the cobicistat or whether we've got to look for other issues. So this is just, again, we don't need to go through this in detail, but just a reminder that there are a number of commonly used antiretroviral drugs that interfere with the tubular secretion of creatinine, cobicistat being one of them. Dolutegravir having a fairly similar effect, lesser effect with rilpivirine, and with some of the other integrase inhibitors. And this effect is similar to the effect of trimethoprim. So at treatment doses, trimethoprim does the same thing. The effect of ritonavir is seen in vitro, but is I would say, less clear whether that's a clinically relevant effect. And that's, I think, an important question still out there. So I'm interested from the audience how many of you have ever ordered a cystatin C. So your choices are yes, no, or what the heck is cystatin C? Great. All right. So maybe I should have made this my pretest question. If I thought it was more important, I would have. There's a lot more discrepancy here in the answers. So about 14% of you say that yes, you have. 41% say no, and 45% say what the heck is cystatin C. So we'll talk about that in just a moment. So I think this is, So cystatin C is an alternative measure of GFR. It is produced by nucleated cells rather than just by muscle cells, and it's cleared by glomerular filtration. So it's used similar to creatinine as a test of convenience. Creatinine happens to be there, cystatin C happens to be there, and they both happen to be filtered by the kidney. So you can use either one of them as an estimate of how well the kidney is doing that job. The pluses are that it has no issues with muscle mass. So obviously, if somebody's very frail or very muscular, it doesn't really affect that. And there are no known issues, at least at this point, with tubular inhibition. So it's not affected by a drug like cobicistat or dolutegravir. It's not affected by treatment doses of trimethoprim or by some of the oncology drugs that also have this effect on tubular secretion of creatinine. On the downside, it can be elevated due to inflammation. So if you think about what one common type of nucleated cell is in the body, it's white blood cells. And so as white blood cells increase in number, this can increase the cystatin C out of proportion to the change in kidney function. So that's really the downside. All of these tests have limitations. And so cystatin C would be a complementary test, not a replacement for creatinine. I tend to not use cystatin C that often, but this is the type of scenario where it can actually be quite helpful, recognizing what its limitations are. So in a patient like this who's otherwise, well and healthy, and probably, although he may have some underlying systemic immune dysregulation from his chronic HIV infection, is certainly not somebody who's got an active infection or other active immune issues going on. So this case fortunately had a Hollywood ending, which is that his serum creatinine was 1.3 on the day that I checked it, which was actually a little lower than it had been. His cystatin C was 0.77, and these measures have been calibrated in the last several years so that people can look at a cystatin C kind of like they would look at a serum creatinine. So that didn't used to be the case, and it used to be very difficult for, I think, like a surgeon or me often to think about what to do with the cystatin C. But now this looks just like the normal range is essentially similar to a serum creatinine. And there are GFR estimates also from the CKD-EPI study based on cystatin C. And so if you look at the comparison by using creatinine only, his eGFR would be 76. With cystatin C, it would be 113. So this is a pretty substantial difference, and this 113 is completely normal, suggesting that this is all the effect of cystatin C and his cobicistat. I'm sorry, creatine in the cobicistat. The other good thing that was reassuring in this case is that his urinalysis is negative and his urine protein creatinine ratio was less than 200, so normal, suggesting that there's also no other evidence of kidney injury in this patient. So this is a patient who I can tell you don't have kidney disease, and the question is just what you do going forward. By the time I repeated this creatinine, I think he had stopped his creatine, and so I would say that his new baseline creatinine is probably 1.3 on the cobicistat. So as long as he's on a stable antiretroviral regimen and his creatinine is stable, I think it's reasonable to continue to follow the creatinine. It comes back faster, everybody knows what to do with it, it costs less money, so I would probably stick with the creatinine unless there's some change in his medications or his clinical status, in which case the cystatin C might be helpful again. I'm going to have one slide on HIVIN, which is what we worry about in a patient like that who's young and shows up. I think no talk on HIV-related kidney disease is complete without a slide on HIVIN, but obviously we're seeing less and less of this disease with effective treatment and earlier treatment of HIV infection. Again, just as a reminder, this is a disease that's strongly genetically linked to mutations in the APOL1 gene. I think this actually appeared on the boards a couple of years ago. It typically occurs in patients with more advanced HIV, at least classic HIVIN does, and it's responsive to antiretroviral therapy. And by responsive, that doesn't mean it goes away. So if you catch somebody very early with early, low-grade proteinuria and a normal creatinine and start them on antiretroviral therapy at that point or encourage them to adhere to their antiretroviral therapy, those patients may actually have a fairly complete remission of this disease. But once patients show up the way we usually see them, the patient who has a new diagnosis of HIV infection or who hasn't been taking their medications, once they show up in the hospital with nephrotic syndrome and have a biopsy that looks like this one below, there's not a whole lot that you're gonna do there. So this is a collapsing form of focal segmental glomerulosclerosis. It's got some tubular and interstitial changes associated with it. It's a really aggressive disease when it gets to this point. And those patients can have some stabilization and maybe even be able to come off dialysis if that's been required. But if you re-biopsy this patient again 6 months after therapy, you'd still find pretty extensive kidney damage. And so these patients are going to be left with chronic kidney disease. So this is why it's so important to make sure that people don't get to this point. What happens with HIVIN in 2020? So as I mentioned, we're not seeing as much of it, but we still see it in patients who are ART naive or who are not adherent with their therapy. And at the same time, there's been a rise in non-collapsing focal segmental glomerulosclerosis, and it's unclear whether that reflects partially treated HIVIN. So HIV may still be there in the kidney. Some of the host responses to HIV may still be at play, but it's sort of partially treated because of their viral suppression. So we don't know that. This is an area of active research, but I think it's pretty clear that all of these patients now should be on antiretroviral therapy, regardless of their kidney disease. So I think the discussion about whether this should be an indication for therapy is no longer so relevant, but still sort of an interesting question. In addition to HIVIN, which we're seeing less of, even with that, we're still seeing more chronic kidney disease in this population and then in sort of age-matched general population. So less HIVAN, more classic FSGS. We're also seeing some immune complex disease. Some diabetic nephropathy and hypertensive kidney disease are becoming more and more popular, more and more common as this population ages. And drug toxicity is also certainly a consideration. I'm going to talk just a minute about immune complex kidney disease, partly because there's a change in the terminology that might be helpful to know about. So the causal relationship to HIV infection is less clear with most forms of immune complex kidney disease. Part of the challenge here is that this is a wastebasket, and in the past we've used the term HIVIC or HIV immune complex kidney disease, and that's included multiple different glomerular diseases, IgA nephropathy and membranous nephropathy and membranoproliferative, and all of these things kind of lumped together, which has made it really hard to determine whether any or all of them are related to HIV infection directly. There's also no animal model, so a lot of what we know about HIVAN is based on animal models, and there's really not one for immune complex kidney disease in this setting. So based on this, KDIGO, which is the guidelines organization for nephrology, has replaced the term or recommended replacing the term HIVIC with immune complex kidney disease in the setting of HIV, and then specific immune. So this is membranous nephropathy in the setting of HIV, or this is IgA nephropathy in the setting of HIV. And the hope was that this would encourage pathologists to report the cases that way, encourage researchers to be able to not lump the diseases together, but actually consider them as individual immune complex diseases in hopes that we would learn more about them. Based on that, the chair of the committee who came up with this recommendation actually looked at a bunch of biopsies from their referral center at Columbia in New York. This is Vivette Degati, who's a renowned renal pathologist, and she essentially looked at the last 10 years of biopsies as over 400 biopsies in HIV-positive patients that were referred to them. And actually, they not only noticed that there was still a decent amount of HIVAN among these patients that were coming to biopsy, and among the immune complex kidney diseases, there was a small number, about 10 or 12 cases, that didn't have another etiology. So there wasn't lupus or hepatitis, viral hepatitis co-infection or some other reason to have an immune complex kidney disease, suggesting that there may be a small portion of these cases that are truly HIVIC, really HIV-induced kidney disease, immune complex kidney disease. So this is an area of ongoing research, and hopefully we'll have more understanding of the sort of natural history and appropriate treatment for these patients. For now, obviously, they should all be virally suppressed on antiretroviral therapy, and for the most part, if patients have stable and well-controlled HIV disease, they should be treated like IgA nephropathy that happens to be in the setting of HIV or membranous nephropathy in that setting. So patients who can tolerate immunosuppressive therapy should be treated just like anyone else at this point. Probably the biggest problem, and I have to say when I was seeing patients in the HIV clinic alone for kidney disease, the vast majority of what I saw was comorbid kidney disease. So these are patients with diabetes and hypertension, occasionally with viral hepatitis co-infection. And this is, I think, not surprising. We know that traditional risk factors for chronic kidney disease are common in this population, and I've listed some of them here. Black race, based on that genetic predisposition that I mentioned before. Although APOL1 genetic predisposition is strongest for HIVAN, it also is a risk factor for FSGS, non-HIVAN FSGS, and for other forms of kidney disease as well. Diabetes and hypertension are obviously increasingly problematic in this population. Hepatitis virus co-infection, and there's a lot of smoking. And although smoking is not as strongly linked to kidney disease as it is to cardiovascular disease, it's certainly another contributor. There's some data to suggest that some of these traditional risk factors in HIV may have an additive or even synergistic effect in promoting kidney disease. In particular, most of the data come from diabetes, suggesting that the progression of kidney disease is faster in someone who has both HIV and diabetes than someone who has either of those diagnoses alone. So this is important to know. It's not just that our patients that we're not doing a good job, but this patient population does probably have some predisposition, whether it's inflammatory pathways or medication interactions, whatever the case may be, but they are more likely to progress. So I'm going to pause there and talk a little bit about antiretroviral nephrotoxicity. I put this slide up because I still remember standing in front of this poster at CROI back in 2010. And these were data from the Euroceta cohort, and this was really sort of that first study that suggested that there was an association between cumulative use of atazanavir and kidney injury. I think no one was surprised about the tenofovir. This was obviously TDF or Tenofovir, but the atazanavir caught people's attention. So I'm just going to put this up to say I'm going to talk mostly about tenofovir today, but just as a reminder that certainly some of the protease inhibitors have also been linked to kidney injury. I think that link, the causative relationship there is quite clear for the older PI and Tenofovir, a little less clear, but probably true for atazanavir. And then I think for some of the other protease inhibitors, the question of whether there's some ritonavir creatinine secretion effect may not be completely irrelevant. So this, again, is another old slide that really summarizes the fact that at least in randomized clinical trials, there was very little effect of tenofovir on creatinine clearance, but then in observational studies, it seemed to have a negative effect on kidney function. Again, none of this is news to anybody here. Similar effect with proteinuria. These are data from an ancillary study to one of the HIV treatment trials that was comparing TDF-FTC to abacavir 3TC. And you can see that in naive patients who started therapy with one or the other agents, proteinuria and albuminuria both went up on the tenofovir-containing regimen and down on the abacavir-containing regimen, again, suggesting that there's, again, I think this downward trend suggests that maybe some of these patients had an early HIV-related phenomenon, and this upward trend suggests that tenofovir does something not so great to your urine protein. In the minority of patients who present with a proximal tubulopathy, which was really initially thought to be the only clinical manifestation or kidney manifestation of tenofovir toxicity, you can make this diagnosis by biopsy. Often it's pretty apparent clinically. But these biopsies give us a little bit of insight into the potential mechanisms of injury. This is just a picture of the proximal tubules, and these tubules are supposed to have these nice little furry borders on them that are gone. That's called the brush border, and the brush border is completely gone, and this is just kind of a big mess. So this is what you would see under light microscopy, and then on electron microscopy, you often see a lot of mitochondrial damage, suggesting that similar to some of the other nucleoside agents, that this is a mitochondrial toxin. And that's still thought to sort of the leading thought for how this toxicity occurs, although we still don't really know exactly what tenofovir is doing to these cells. But we do know that in addition to glomerular filtration, tenofovir is actively secreted by proximal tubular cells. So there are very high levels of tenofovir in those cells, which would explain why maybe the mitochondrial effect is greater there than it is in other parts of the body. The good news is the tubulopathy is largely reversible. So if somebody gets Fanconi syndrome from TDF, that can go away because tubules have a pretty good capacity to regenerate. The problem is if patients have if this has been allowed to go on for long enough and they've developed a decline in GFR, that's less likely to fully recover. Risk factors, and again, these are not going to be surprises for anybody, are boosted protease inhibitors, lower baseline creatinine clearance, female sex, and low body weight, all things that increase the serum concentration of tenofovir. I'm going to add here ledipasvir, which we're using less of, at least in the United States, but certainly still being used for Hep C in other places, and cobicistat. So it's important to remember that cobicistat also raises tenofovir exposure in the setting of both TDF and TAF. So cobicistat can have a similar effect on increasing potential risk. So I'd like to just pause here and find out how many of you guys have switched patients, or sort of what people's patterns have been in terms of switching patients from TDF to TAF since its approval in 2016. Okay, so it looks like about 2/3 of the group has switched most of their patients, or over 75% of their TDF-treated patients, to TAF. decent chunk of folks have done that sort of in the 25 to 75% range. So a lot of their patients, but not all. And then a small number of people haven't really switched anyone, or very few people, which is, I think, probably pretty consistent with practice as I've seen it as well. So what about TAF? So again, this is just an alternative tenofovir prodrug, and it's important to remember in the back of your mind that this is still tenofovir. So the reason that this is thought to be have the potential for less kidney and bone toxicity is because there's lower plasma exposure to tenofovir itself, substantially lower plasma exposure in patients with normal kidney function and without other risk factors for higher exposure. Fixed dose combinations are approved for HIV, and standalone TAF is approved for hepatitis B. I know some people are using it for HIV as well. So again, I just put this up as a quick reminder that that we have seen. You can see a difference in creatinine clearance over time. This is actually Cockcroft-Gault creatinine clearance difference in that over time in patients who are taking the TAF-based regimen on top versus the comparable TDF-based regimen on the bottom. This initial blip here, I'll suggest is the cobicistat effect, because this was ECF-TAF and ECF-TDF. So again, this is what happens initially when you start cobicistat, that little drop in rising creatinine drop in GFR. But again, eventually this looks like it favors TAF. Similar things, and this I just showed this because it's kind of the corollary of those data that I showed before. So now there's a benefit of TAF compared to this, again, this decrement a benefit with TAF as opposed to the decrement in or increasing in proteinuria and UACR with TDF. So this is also similar with other markers of proximal tubular function. I didn't include those data here in detail because we don't use them as often clinically, but if you look at retinol binding protein, for example, or proximal reabsorption of phosphate, all of those things would show similar trends, suggesting that at least proximal tubular function is better on TAF than TDF. That doesn't necessarily mean that there's more injury with TDF and TAF, but it does suggest that there's some early effect on function at the very least. So in a patient where you're concerned about phosphate wasting, you might, even if you're not worried about their kidneys, you might still want to err on the side of being cautious and going with TAF. I'll say that there is still some controversy about whether there's going to be a real clinically significant effect here. There are limited data on hard clinical outcomes or long-term outcomes, the things we'd really care about, like if fewer people get kidney injury. The limited data that we have, there's a pooled analysis of data from 26 randomized trials, suggests that there's probably a lower risk of proximal tubulopathy and drug discontinuation for renal adverse events, but this doesn't necessarily answer all the questions that we want to have answered. So I think it's probably not unreasonable when someone asks the question of whether there's still a role for TDF. And I think there may be in some settings, if patients aren't able to get access to TAF and a tenofovir-based regimen is still the best alternative for them, then I think it's not unreasonable to continue some patients who are otherwise low risk on TDF. But, I think most of us would be inclined to switch to TAF in the interim just because it seems likely to have less toxicity. I'm going to point out, and again, I've reminded you of this before, but that TAF is still tenofovir. It's just a prodrug of tenofovir. So there are settings where levels can start to approach those that we see in patients who are treated with TDF. So both TAF and ECF-TAF are approved for use in patients on hemodialysis, which is reasonable. Otherwise, they're approved for patients with creatinine clearance of greater than 30, and there's sort of that gap in between those people who have more advanced kidney disease but are not yet on dialysis. At least at this point, there's no FDA label dosing recommendation for those patients. But it's important to remember that these drugs can still have impacts on bone, on residual kidney function, and I'll talk a little bit about peri-transplant management relevant to the pretest question in a second. But if you've got a patient who's on dialysis, still makes some urine, and you've now got them on, full dose ECF, you don't have a choice about full dose versus not, but you have them on ECF-TAF, they're going to be exposed to levels of tenofovir that may be pretty comparable to what patients have been exposed to for years with TDF. So with some potential for, in fact, impacting their residual kidney function, which is an important predictor of outcomes in patients on dialysis. There are also patients on dialysis also have plenty of issues with bone. They don't need other things causing it. So certainly that would be another consideration in these patients. And then I'll come back to the peri-transplant piece in a minute, but it sounds like you guys are pretty comfortable with the drug interactions between cobicistat and some of the immunosuppressive agents. I'm not going to talk much about PrEP, but just a reminder that there's still some use of TDF-FTC for PrEP. There is certainly data to suggest that there can be toxicity in this setting as well, although I think in the vast majority of patients, and particularly in resource-limited settings where it's not going to be reasonable, at least for now, until there are good generic formulations to use FTC TAF. I think it's still probably much better to get access to PrEP with some very small risk in an otherwise healthy individual rather than not being treated at all. So I'm going to shift gears here and talk a little bit about management of kidney disease in this population. And I think this is actually where the vast majority of the questions came from the pre-registration question. So I do want to spend some time on this. I think sort of the basic ideas here are that these patients should be co-managed with nephrology. This is true for a diabetic without HIV. I want them to be managed between an endocrinologist and myself. So I think this is pretty uniform to what we would do in the general non-HIV population. Patients, at the very least, need to be referred early enough for us to plan ahead for ESRD, but ideally early enough for us to intervene and help to delay progression, particularly if there are questions about the potential diagnosis. And I think consideration of kidney transplant is another important reason to involve a nephrologist early. So what can we do as nephrologists? I think first is establish a diagnosis, which is often unclear. So, things that we do will quantify urine protein. So if you're going to send a patient to us and they already have a urine protein creatinine ratio, that makes our life much easier in that first visit, because we at least know from starters, whether or not we're talking about a patient where a biopsy might be helpful. Kidney biopsy tends to be more useful in patients who have a moderate or high amount of urine protein that suggests a glomerular disease. Or, if you're unsure and you suspect a tubular damage, these days if you suspect that tenofovir is the problem, you would stop it. But if there are other things that you think might be going on where a biopsy could be helpful, we'll do it, particularly if we think it might alter management. So if it's going to change treatment, if we suspect an immune complex disease where I mentioned that you might treat them with immunosuppressive therapy, for example, then kidney biopsy can actually be very helpful. Also, nephrologists, I think, and this is true even for endocrinologists who spend a lot of time taking care of patients with diabetic nephropathy, but still don't think much about bone mineral disorder and anemia. So kidney's main job is to act as a filter, but you have to remember it does a lot of other things. It's a partner, sends a signal erythropoietin to the bone marrow. So patients with progressive kidney disease, obviously anemia can be an issue. We still like to let you guys do the ESA if we can. It's such a pain, but and then patients often develop bone mineral disorders. There are several questions about effects on phosphorus and vitamin D. So the common bone mineral disorder in this setting is that patients fail to activate vitamin D, so their 25D levels can be low or normal, but if you were to check, which I don't often do, but if you were to check a 125 vitamin D, you'd find that it was low. So suggesting the kidney is no longer performing that step in activation. And that often results in low serum calcium levels, and as a result, you end up with a high parathyroid hormone level, and then the whole cycle begins. So this is, you guys feel free to manage it if you want to, but it's another good reason to partner with a nephrologist, because this is something we think about a lot. And there are ways to address this. Often we'll just start patients on activated vitamin D or calcitriol, but that requires monitoring of calcium and phosphorus to make sure that you're not raising that product too high to cause complications. So this is sort of another area that we can be involved. You can probably do a lot to delay progression on your own without referral to nephrologist. If somebody's got diabetes or hypertension, then optimal control of those diseases is really important. For some reason, nephrologists seem to scare patients into doing it, at least for a little while. I'm not sure if they associate us with dialysis or what it is, but male scare tactic sometimes works. The other thing that's important to talk to patients about is NSAID use. because it's actually, quite common for patients to be using over-the-counter NSAIDs and not really mention it to their providers. And certainly, at least at moderate doses, those can have a substantial effect on kidney diseases, in particular diabetic kidney disease, as well as on management of hypertension. The other medicine I'm just going to mention briefly here is proton pump inhibitors. I'm not going to talk about this in detail, but there was one question related that sort of made me think about this. I also talk to the patients about their indications for a PPI. I'd say probably 50% of the patients referred to me are taking one, and maybe 50% of those people have a strong indication, like an ulcer or refractory heartburn or something like that. But many of them are just taking it because it got started at some point, or they had a cough, or I don't know, they like to eat spicy food at bedtime. And there are some epidemiologic data to suggest that PPIs may increase the risk of kidney disease. Not data that will hold up in court, but reproducible enough in multiple studies in different populations to suggest that there's probably something real there, and that if people don't need them, they should stop them. What else can we do? So I mentioned avoidance of NSAIDs and nephrotoxins, optimal control of CKD risk factors, and just a couple of details that I wanted to talk about here. First-line therapy for hypertension in patients with kidney disease really should be an ACE inhibitor or an angiotensin receptor blocker. This is most important in patients who are diabetic or who have proteinuria. So if somebody doesn't tolerate an ACE inhibitor for their hypertension or an ARB for their hypertension, and they don't have proteinuria and diabetes, then I wouldn't push the envelope there. But in a diabetic or somebody who's got urine protein, then these are clearly first-line agents. Diuretics are a good combination with these, so that would sort of be my first-line therapy, would be probably hydrochlorothiazide and either an ACE or an ARB. In patients who have diabetes, if they can tolerate an SGLT2 inhibitor and they have CKD, that's also recently been shown to have a pretty profound effect, and profound, at least profound for anything in nephrology, effect on cardiovascular and kidney disease risk. So again, if patients can tolerate them, the diuretic effect can be a challenge for some patients, but if they can tolerate them, that's another thing to consider. And then finally, I mentioned targeted treatment. I don't need to talk about this anymore, but again, just a reminder, if we find a treatable disease, we should treat it. And if we don't look for it, we won't find it. So what about patients who unfortunately do progress? So I didn't really talk much about it, but I should just mention before talking about transplant that these patients are candidates for hemodialysis or peritoneal dialysis. And that the early referral is helpful so that they can make that decision before they're sick, and if they choose hemodialysis so that they can get a fistula placed early as possible. It takes an average of 6 months for a fistula to be ready to use, because partly because it takes a while to get them placed, but also because there's a fair amount of operator variability in success rates, and it takes some time for them to heal. So I would, give yourself some lead time for patients who want to do hemodialysis so that you get the best possible chance that they'll start dialysis with a fistula rather than a catheter. And again, those patients, really the decision between hemodialysis and peritoneal dialysis, with a few medical exceptions, is based on patient preference. I think, people sometimes have concerns about patients who have poor adherence and peritoneal dialysis, but those same patients just don't show up for hemodialysis. So, it really should be based on patient lifestyle, patient preference, and then, some consideration of factors like patients with an extensive history of abdominal surgery may not be a good PD candidate. Patients with horrible vascular disease may be better PD candidate because they can't get a decent hemodialysis access. So with that, I want to talk a little bit about kidney transplant, which really should be the optimal treatment in this population. So outcomes are good. There are similar rates of opportunistic infections to the general transplant population. There is, importantly, a higher risk of acute rejection, particularly with kidneys, in patients with HIV. And this is probably related to the drug-drug interactions, although there's some consideration still that there may be some effects of immune dysregulation. Interestingly, there's limited data on the mortality benefit. So we know in the general dialysis population that there's a strong mortality benefit to getting a transplant compared to staying on the dialysis waiting list, on the waiting list and on dialysis. We don't have similar data, at least not the same level of data in patients with HIV, but I don't think there's much reason to think that they would be different, as long as drug-drug interactions are managed appropriately. So I think, if I were one of these patients, I would want a transplant. I would not want to be on peritoneal dialysis or hemodialysis. I would probably choose PD if I needed something as a bridge to my transplant. And so I think that, making sure patients are referred early enough so that they're aware of all their options and can really make the best decision for them is important. With that said, there is significant potential for drug-drug interactions in transplant in patients with HIV. And I would say, if possible, just avoid protease inhibitors and cobicistat in these patients. The drug interactions between PIs and COBI and the calcineurin inhibitors, that's Prograf and cyclosporin, which are really sort of the central part of immunosuppressive therapy for most patients. Those drug interactions are so strong that patients can often go, instead of taking Prograf, for example, twice a day, sometimes these patients are taking it once a week. And although their trough levels may be in the target range, you can imagine that there's a huge amount of variability in their exposure to those drugs over time, and it's thought that that's the reason for the higher rejection rates in this population. It also is a challenge if patients are having a liver transplant, for example, then probably the peak levels are much higher in these patients who are getting higher doses once a week than instead of sort of more lower, more intermittent doses. And so that can be an issue for the kidney as well in patients with other solid organ transplants. So again, if possible, and ideally this should be done before transplant. So if you've got a patient who's on hemodialysis or peritoneal dialysis and they're listed for transplant, they've been listed for a while, and they're on a regimen with cobicistat in it or a PI in it, it's probably worth talking to the transplant team about whether that regimen should be changed now, because it's always nice to know that people are going to tolerate their new regimen before the transplant instead of finding out after that you have limited options. So I wanted to spend a minute talking about the HOPE, which was sort of one of the things that we talked about in the pretest question. This is a picture of Elmi Mueller. I put it here mostly because I think she looks like a badass, but she's a transplant surgeon in Cape Town, South Africa, and she found back in around 2008, 2010, she started seeing more like 2005, she started seeing patients who were dying from HIV and end-stage kidney disease, and buckets and buckets and buckets of discarded kidneys from patients who were HIV positive who died. So potential donors whose organs were being discarded, potential recipients who didn't have access to transplant, because at the time that she started her crusade, there was really limited access to dialysis, limited access to antiretroviral therapy, and no access to transplant for patients with HIV. So she said, what the hell, I'm going to see what happens if I give one of these discarded organs to one of these, patients that were otherwise going to discard too. And she found that most of these people actually did pretty well. And so she published an initial round of short-term outcomes in 2010, 3 to 5 year outcomes in 2015, really suggesting that it was not an unreasonable thing to do, to give an organ, an HIV-positive organ from a deceased donor to an HIV-positive recipient. This eventually prompted change in the U.S. law in 2013, and this is a picture. I largely just like to see Obama's face now and again. This gentleman back here in the back left corner is Peter Stock, who's a transplant surgeon at UCSF. So this was the signing of the HOPE Act by Obama, which made it no longer illegal to use a deceased donor organ from an HIV-positive individual. And then OPTN, is the Organ Procurement Network, changed their policy in 2015 to allow the use of HIV-positive donors. And so this has allowed for, at least in research setting, the use of these organs in our patient population. There is an ongoing prospective study that's looking at graft and HIV outcomes and impact on waiting time. I think it looks, I don't have much doubt about the good graft outcomes, because we know that from South African study. There are more questions about HIV outcomes in the U.S. population because we have more drug resistance here, largely because patients have been exposed to ART for longer than they have in South Africa. So questions about the impact on HIV outcomes still remain important. HIV-positive donation has had much less impact so far on waiting time than Hep C donation has. And this is in part because of the high rate of death of patients with Hep C in the setting of the opiate epidemic. But also, I think because there are just fewer centers that are offering HIV-positive donation. But it does increase the donor pool. And interestingly, there have actually been some false positive organs that have been received as part of the HOPE Act. So, and these numbers have gone up since then, but the published numbers are more than 10 donors and more than 21 recipients who have basically these organs have been saved from discard and then eventually turned out that the donor was HIV negative. So these are perfectly good organs that would have just been thrown away. And overall, the organ quality has been excellent. So part of this is because I think people have a lower threshold for taking an otherwise high-risk kidney, so a crummy-looking kidney on frozen section that's also HIV positive. So some of this has been surgeon and transplant nephrologist driven. But overall, the quality of these organs has been excellent, and in many cases better than what these patients would have received sort of in the open market. So again, I mentioned HIV superinfection, potentially with a different HIV strain with more resistance, is a concern. Donor virus is at least transiently detectable in recipients, but so far there's no evidence that this impacts outcomes. So I think this is an open question, and one of the reasons that I personally think it's still important to do these transplants in at least in a research setting until we know more answers, partly just so that we can gather the information. And partly so that patients know what they're consenting to. So I wanted to end, this was actually was going to be my last slide, just a reminder that not only can we accept deceased donor organs from HIV-positive donors, but there are now some centers are accepting living donors with HIV. And this has started in several centers, altruistic donor chains, so HIV-positive individuals who've wanted for years to donate a kidney, including a couple people who are transplant coordinators, for example, who've always wanted to do this and who have now had the opportunity to donate. So this has been a really positive effect for them, too. So these are incredibly motivated donors and recipients who also stand to benefit. So I had planned to stop there, but then COVID happened, and I thought I should probably just toss in a couple of slides about COVID-19 in the kidney, and then we'll leave some time at the end for questions. I tried to answer some of the questions that I've gotten along the way, but definitely wasn't able to answer all of the pre-registration questions. So if any of those are still burning you up, you should feel free to add those to the list, the comments. So again, I think all of you are probably aware that acute kidney injury is common in patients with COVID-19. More than a third of hospitalized patients in a New York series, and I'm just citing the New York series here, but these data are pretty comparable from other European and U.S. series. They seem to see less AKI in China initially, although they did see a lot of urine protein and hematuria then. Acute kidney injury seems to be strongly linked to ventilator dependence. So in this one series, for example, nearly 90% of ventilator dependent patients required had some degree of AKI, not all requiring dialysis. And other risk factors included age, race, and diabetes, so both being Black race and diabetes. So these are, again, risk factors for kidney disease in many other settings as well. We don't know what's causing this acute kidney injury, and I think it's probably multifactorial. So we know that their sort of cytokine storm seems to be causing a lot of the bad complications in patients with SARS-CoV-2 infection. There's some of these patients are remarkably hemodynamically compromised. There's evidence of dysregulated coagulation. There may be ischemia reperfusion injury. The fact that these patients who are ventilator dependent are having such high rates suggests that maybe there's something to do with that reperfusion that's bad for the kidneys. And then the question of whether there's local viral infection like we see in HIV, I think is an important and interesting question as well. Part of the reason I think this is particularly interesting is because there also are some increasing number of case reports of glomerular diseases, most commonly collapsing glomerulopathy, and it looks just like HIVAN. And similar to HIVAN, also seems to be associated with APOL1 genotype, so almost all a high-risk genotype. Almost all of these patients have been African American, and in cases where they've been tested have had 2 copies of the APOL1 risk allele. This is probably an interferon-related disease, which is something that we also know is part of the mechanism for HIV-IM. And finally, I'll just add a note that early on we were optimistic that our immunosuppressed dialysis and transplant patients were going to do swimmingly with COVID-19 because they didn't have the cytokine storm, but that turns out not to be the case. So at least the dialysis population is doing pretty poorly in settings where there are outbreaks or exposures. Some units have done a really outstanding job, and particularly in more recent days, now that we understand more about masking and other approaches to prevent transmission. So I am going to stop there. I'm happy to answer. I am no expert on COVID-19 in the kidney, but I think none of us are. We're all trying to be. So I'd be happy to answer questions about that or about your HIV patients. I probably don't need to go through this question again because everybody got it, or most of you got it right the first time. So just a reminder, this was that reminder about the cobicistat and calcineurin inhibitor interactions. So reminder that you could watch this webinar again if you didn't learn anything the first time, or if you took a break and went to do something else. You can also claim your CME credit online. And I'll open things up for questions now. So let's see. I'm going to pan over to the notes question. One question that I know I didn't answer and I had meant to, one pre-registration question was about hypertension goals in patients with HIV. I mentioned that I would use as first-line agents ACE inhibitor or angiotensin receptor blockers, but I didn't talk about goals. And part of that is because I don't actually know the answer. This seems to be a moving target. Each time there's a new set of hypertension guidelines that those targets change. It's pretty clear that everyone should be less than 140/90. Probably patients with diabetes or kidney disease should be lower, whether that's 135/85 or 130/80. And then, if you look at the latest ACC-AHA guidelines, they would suggest that if patients have other reasons to have increased cardiovascular risk, and HIV might be one of those, that their goals should also be lower. So, that's assuming you can achieve those goals, but I think somewhere in the 130 to 140 over, over 80 to 90 range is probably the right number. So, again, a moving target, something to keep an eye on, but I would probably consider lower goals in patients, at least with kidney disease or diabetes. There's a question here about nephrotoxicity of tacrolimus, and I can toss it out quickly. So this is true, and this is probably more relevant for other solid organ transplant recipients other than kidney. So ironically, both tacrolimus, that's Prograf, and cyclosporin are nephrotoxic drugs as well. We use them to protect kidneys from acute rejection, but it also at the same time over time causes injury to the kidney, and we know that. Unfortunately, those drugs also cause injury to the kidney in patients with other solid organ transplants or bone marrow transplants if they're exposed to these drugs. So the highest rates are probably small bowel transplant recipients, lung transplant recipients, where the doses of those agents, the target doses, are much higher. Less so in liver and sort of intermediate in heart. So yeah, if you're following patients or you have patients with other solid organ transplants, those drugs are nephrotoxic, and particularly if they're used in combination with a drug like cobicistat or a boosted protease inhibitor. There's significant potential for kidney injury in that setting. So that's a good question. Let's see, I'm just looking for good, interesting question. So we mentioned APOL1 a couple of times. Is it a risk factor for tenofovir toxicity? Probably not. So the data that we have available to us so far would suggest that tenofovir is sort of a little bit more agnostic to race than some other kidney diseases. So the vast majority of kidney diseases are black race is a risk factor, and black race incorporating a lot of patients with the APOL1 high-risk genotype, which is almost exclusively in patients who are of West African descent. That does not seem to be the case for tenofovir. So I think tenofovir doesn't care as much about it, but that's a good question. It does appear APOL1 may be a risk factor for COVID-related kidney injury, but we don't know that for sure. But So, and I think some of these were asked before I answered, but just as a reminder that patients who are getting TDF for PrEP also have some risk of kidney toxicity. Risk factors would be the same, with the exception of the fact that they're less likely to have drug interactions with things like COBI or protease inhibitors. But yeah, there is some evidence of kidney injury in that population. It's much less common because they have fewer drug interactions, often tend to be healthier and younger, but it is certainly possible. And would I say that TAF is preferable to TDF for PrEP? Not necessarily. I think in a healthy individual with less risk for drug interactions, particularly if it's not going to be used long term, I would probably use TDF preferentially at this point, or FTC TDF. In patients who, if you've got an HIV positive partner who's having trouble with viral suppression and you're going to be on PrEP for the long term, then I guess I would think about sort of risk. If this is a diabetic or a patient with underlying kidney disease or a particularly small, frail individual, then I might be more inclined to use the FTC TAF. But otherwise, I think that probably there's still a pretty good role for FTC TDF in the PrEP setting. Good question. I don't know the answer to it, but I think somebody raised the point that that there is less favorable effect on lipids with TAF than with TDF, and I think that's a really important question that we don't know the answer to, whether or not that's going to have any impact on cardiovascular outcomes. And that's an important question in patients with kidney disease because kidney disease is actually probably a cardiovascular risk equivalent, similar to diabetes. So if you think about now you're, say this patient's at high risk for kidney disease, so I'm going to put them on TAF instead of TDF, are you now increasing their risk for cardiovascular disease? By losing, I think it's not that TAF has a negative effect on lipids, but that TDF actually had a favorable effect on lipids. So on balance, I don't know the answer to that question, but I think it's actually a good one. My favorite patient question. So this is a good one because patients ask me this all the time. Is there anything you can do about nutrition to prevent or reduce kidney disease? And there's not much, is the short answer. So in patients with very advanced kidney disease, we know that we can delay symptom onset and potentially delay the start of dialysis by reducing protein intake, and that is just at the very end. So when patients are at risk for becoming uremic, sometimes we can delay some of those symptoms by reducing animal protein intake. Obviously, those patients also have to watch out for potassium and phosphorus. In earlier stages of kidney disease, there's really very little evidence that much, if anything, that we do apart from sodium reduction for blood pressure control does anything to prevent or delay kidney disease progression. So I focus on salt in my patients because most of them are also hypertensive and generally not well controlled there. So, and so many of them are also diabetic that if I'm going to talk about glucose control, I'm going to talk about, low salt diet for their hypertension. I really don't talk much about other nutritional approaches because the data for those are not as strong. So that's a great question and a very common question from patients. So thank you for asking that. What significant change in creatinine? So what do I use to stop? What would I use as my benchmark to stop TDF and switch to an alternative, whether that be TAF or an alternative, that's tenofovir sparing regimen? I think that depends. If you see somebody with just a sort of gradual creatinine creep, it's hard to know. I've been asked recently this question about aging. There is a creatinine creep with aging. There's a GFR decline that happens with aging, and some of that is physiologic, some of that's not. Some of it really does reflect damage from, our years of abuse to our kidneys. And so sometimes it can be tough to tease out. And, you've got a patient with diabetes and progressive kidney disease. At what point do you say, enough's enough, I think this is tenofovir? Or at what point do you just say, I'm tired of paying attention to it and I just want to take something else out of the equation? So I think a lot of it depends on how closely you're willing to monitor, whether there are challenges to accessing TAF or reasons that you can't switch them to a tenofovir sparing regimen. So I think it is pretty individualized. If you're looking for numbers, people would say that a decline in GFR of greater than 3 mLs per minute per 1.73 meters squared, so greater than 3 per year would be considered a more rapid decline. and an indication for considering this to be a real issue. Yeah, so question about the use of cobicistat in general in advanced kidney disease. Yeah, in stage 3 kidney disease or higher. I don't have a problem with cobicistat in the sense that I think that cobicistat, the effect of cobicistat on creatinine is benign. So as far as we know, having more creatinine around isn't a bad thing. So I just, for example, started a patient, not HIV, but a patient on dialysis, and his creatinine was 26, and he had some problems, but they're not from the creatinine at 26. His hemoglobin at 3 was more of a problem. So the creatinine itself is not really a toxin, just like BUN in most cases is not really the uremic toxin. So if cobicistat makes the creatinine go up a little bit, I don't care so much. I do care when patients are taking cobicistat in combination with tenofovir, and I say tenofovir because I actually mean both TDF and TAF. And I didn't touch on this, but I think this was a question raised in pre-registration that's an important reminder, which is that cobicistat does also raise tenofovir levels in patients on TAF. So if you look, for example, at the co-formulated ECF TAF, the TAF dose is lower, right? It's 10 milligrams instead of 25. And so if you're suddenly now taking a patient and putting them on, I don't know, FTC, TAF, and boosted atazanavir, Cobi boosted atazanavir, or ritonavir boosted atazanavir, that for that matter, that's another one of those patients where you may be exposing them to higher levels of tenofovir and more risk for toxicity, bone and kidney. Let's see. At what point in the course of HIVAN is ACE-ARB use a treatment or prevention? So I'll start by saying in general, outside of diabetic kidney disease and to a lesser extent IgA nephropathy in the general population, the data for ACEs and ARBs is not great. So we use it, we extrapolate from those data to say that in other populations, and I think there's no reason to think that an HIV-positive individual with diabetes is not going to benefit from an ACE and ARB. So I think in those patients, it's pretty clear cut. We've extrapolated to other kidney diseases with proteinuria, and there's some evidence, but not as good for those diseases. So again, I think a person living with HIV with IgA nephropathy or with some proteinuria from their hypertensive kidney disease, again, I think an ACE or an ARB would be first-line therapy. The data for HIVAN specifically are limited to very tiny randomized trials and lots of observational studies where the patients who were, in many cases, patients weren't even appropriately treated in terms of their HIV at the time. Some of them were getting steroids too. So it was kind of a mishmash. I think it's not an unreasonable adjunctive therapy. So first line obviously is ART. So if somebody's not taking ART or they're not taking it well, I would focus on that first. Unless their blood pressure is incredibly poorly controlled, in which case you may want to start both at the same time. But if blood pressure is not really the issue, I think the data for ACE and ARB in that setting are not strong enough to stand in the way of making HIV treatment the primary goal. Let's see. And a related question about ACE and ARBs in the African American population. Unfortunately, patients, African Americans and patients with kidney disease have been included in a lot fewer studies in general of most things. And so the data for ACE and ARB in African Americans is not as strong as it is in the white population. But there's not much to suggest that they don't benefit as well. So I would certainly still use those as first-line agents, both for proteinuria and for hypertension. There are data to suggest that they are less effective for blood pressure control in patients who are African American. So I would probably have those patients come back sooner. And if they're coming in with uncontrolled blood pressure and you're starting just an ARB monotherapy for blood pressure control, which is actually not recommended anymore. So if people have really severe hypertension, the recommendation is start with 2 drugs. That's always a little challenging. You've got patients who already, may have some polypharmacy going on. You want to put 2 drugs, and then you don't know which one causes the side effects. But anyway, 2 drugs. But if you're going to start somebody on monotherapy with an ACE or an ARB, particularly in African American, I would have a low threshold for having to come back very soon to make sure it's working, and a low threshold for adding a diuretic, because together those drugs are actually quite effective for blood pressure in that population. Let's see. So in New York City, somebody asked about how to link with HOPE studies. So if you Google the HIV HOPE transplant online, there's a list of participating sites. I know several sites in New York City are accepting transplants from HOPE, and I would just call their or ask the patient to call their referral line and say they're interested in the HOPE study. Most of the sites are pretty. I know NYU and Mount Sinai are pretty active in that protocol. So I would definitely encourage patients to at least consider it. They may decide that they want to go with a standard organ transplant, but I think it is a good thing to consider at least. I have had some patients where it had a substantial impact on their waiting time. It just overall doesn't seem to be quite as significant as the Hep C. And I would also encourage your patients, and I think your counseling will be important to them, to think about accepting a Hep C donor kidney, particularly knowing what you know about their ART regimen and their other risks for problems with DAAs. But in general, everybody has been doing quite well in those protocols in terms of clearing their Hep C afterwards. And then there's still a bunch of questions. I'm just trying to look through for ones that I think are going to be pretty broad interest. Let's see. Okay, this is the question that maybe the same person, but I had gotten in the pre-reg that there was a question about TAP and nephrotic syndrome. That is not something that I've seen. It's not really something that's been reported in the literature. And TAP is just, TDF light, basically. I mean, it's still just tenofovir. So I can't think of any good reason why TAP per se would be associated with a nephrotic syndrome. Other common causes of nephrotic syndrome just in general, so apart from HIV, NSAIDs are actually probably the most common cause of nephrotic syndrome in the general population that we don't think about, kind of under-recognized. It causes a minimal change disease that can cause nephrotic syndrome. So thinking about NSAID use in those patients, screening for hepatitis B and C as common causes of glomerular diseases that can cause nephrotic syndrome would be important. And then finally, somebody asked a little bit more about cystatin C, which I think is a good question because that was something people didn't seem to know as much about. And cystatin C, are there times when it should not be used? So I don't think there are necessarily times where you can't check it. Are there times where you might be skeptical about the results? Absolutely. I have a patient in my clinic right now who's neutropenic, or actually leukopenic. And I have a discrepancy. She's on one of the cancer drugs that raises creatinine by interfering with tubular secretion. So it has a very similar effect in clinical trials to cobicistat. So again, sort of that 0.2 milligram per deciliter bump in creatinine that's benign and doesn't reflect a change in kidney function. And just as a reminder, in all of these cases, there's a bell-shaped curve. So, right, if most people have a 0.2 milligram per deciliter increase, there'll be some people who don't have any. That doesn't necessarily mean they're not taking their drug. And there may be some patients who have a much bigger bump. And so that's important to consider as well. It doesn't necessarily, if it happens right away and it's stable, it probably is still the drug. So in this patient anyway, I checked the cystatin C to make sure that, thinking I was real smart, thinking I was going to exclude, just prove that it was the cancer drug. And then I started thinking, well, if she's leukopenic, is she just making less cystatin C? So we don't actually know, and I actually have scoured the literature to see if anybody knows the answer to that question, and they don't. So I think just like anything else, you have to think about it a little. But if it's an otherwise healthy, well-controlled HIV patient, and you can't tell because they were referred from somebody else how much of their slightly abnormal creatinine is their COBI or the dolutegravir, I think a cystatin C is pretty useful. Again, thinking if the levels are high, then you want to think about whether they've got inflammation, liver disease, lupus, for example. Those things are settings where the cystatin C is probably not as great a marker. But it's pretty good. It's a pretty good complementary measure to creatinine. I'm definitely not replacing creatinine with it for a lot of reasons, but it is a pretty good marker in settings where you really need to try to tease these things out. So it looks like we are at the hour. I would actually be happy for people to reach out to me directly with questions. I miss my HIV-only clinic. I still see a large number of these patients, but they're mixed in, and I'm not sitting beside the HIV providers like I was before. So I would be really thrilled for people to reach out to me, first name, last name at duke.edu. These days I'm a camp counselor, so in addition to my full-time job, so it may take me a little while to get back to you, but I would be you'd be thrilled to help. So thanks again to everybody for your attention. It looks like almost everybody stuck it out through most of the questions, so thanks for that too, and hope everybody stays well and safe. Take care.
Today's webinar will be available for on-demand viewing and CME credits at the IAS-USA website. CME cannot be claimed for both live and on-demand versions of the same webinar. Evaluations will be emailed by 5 p.m. Pacific time tomorrow, and this will enable the IAS-USA enough time to go over those that have pre-registered and have attended today's webinar. The IAS-USA will be having virtual CME updates on HIV, and the first will be on this coming Monday, which is directed towards clinicians in the West Coast. And then on Tuesday, July 14th, we will have a course directed towards East Coast physicians. Additionally, we will have a Midwest course, and that will be on Thursday, July 30th. The IAS-USA has also began a new series on COVID-19. For more information,